To give a quick introduction while we wait for a few more.
Okay.
So I want to thank you all for joining us this afternoon. And as I mentioned, so we have two interpreters in addition to our panelist speaker. So it is Christina and Amanda. So if you need to pin them, I just wanted to let you know, then they have their titles listed as well. And I'm going to ask that everyone please hold questions and comments until the end of the presentation, because we have made time for Q&A, a little discussion for anyone that is interested afterwards. So I'm Ariel Morris, and I'm the Family Resource Specialist for Early Hearing Detection and Intervention with Parent Information Center of Delaware, and I host these bi-monthly learning communities. So please be on the lookout for some more information for those to come towards the end of the summer. For those of you not familiar with PIC, it is a 501c3 statewide organization with a mission to advance effective parent engagement in education, and especially focus on supporting families of children with disabilities from birth to age 26. So now I think we'll get started. So I'm going to introduce our panelist today, Dr. Kathi Riley, and I'm going to thank her very much for speaking with us this afternoon. Dr. Riley is an educational audiologist with 39 years of experience working with children with hearing loss, their families, and service providers. So now I will turn it to you, Dr. Riley, who is speaking on the topic of congenital CMV awareness. Thank you.
Thanks. And just for the interpreter's sake, my name sign is Riley, so that will make it easier. Everybody knows me, Kathi Riley, right? So I am Dr. Kathleen Riley. I am an educational audiologist. I have a doctorate in audiology. As Ariel said, I have spent most of my career working with children and families and all the related service providers that serve them. Of interest to me has been a particular virus that causes hearing loss called cytomegalovirus. So it is a mouthful. You'll hear cytomegalovirus or cytomegalovirus, depending on who's saying it, but whatever. People tend to just call it CMV because it is a mouthful, okay? So kind of my goals for today would be that you all understand what CMV is and is not, what its impact is, and how it's transmitted, okay? And then I'd like you to be able to understand the different methods of testing for CMV, the timelines that we need to follow, and then the validity or reliability of different kinds of testing, right? I also want you to recognize the precautions and behaviors that limit the transmission of CMV to pregnant women. Those women are our target audience, really, when it comes to CMV. I'd like you to know where to access informational materials and or research, if you're that person, that you can read yourself, but also that you can share with others. I'm really big on the last piece, which is I want you all to join me in kind of supporting public awareness. And there's a small group of us that are working together to try and get standard screening for CMV for newborn babies. All right, so that's kind of our goals for today. And I know Ariel said we have questions and answers at the end. If you think you might forget, just go ahead and put it in the chat, and then we can scroll through that later, okay? All right, so what is CMV? CMV is related to the herpes virus, and the herpes virus actually takes several forms. So there is herpes itself. There is also CMV. There's chickenpox and shingles. They're all in the same family of virus, right? when you or I get CMV, we very likely might be asymptomatic. We don't even know what's happening. Or we might have a cold, right? So back when I started in my career, we used to think that there was only one form of CMV, and that if you were positive for CMV, it meant you had the antibodies and you could never catch it again. We now know from newer research that that's not true. That like all viruses, colds, the flu, COVID, they all mutate. And there are different kind of mutations or varieties of CMV. So you can contract it more than once. It is spread through bodily fluids. So the primary spread is saliva, but it's also found in urine, blood, tears, mucus, and breast milk. Okay. I find this slide interesting. I borrowed this from the National CMV Foundation, who we're partnering with. And it shows you how many women have ever heard of CMV, right? It's very few. And yet it's more common than most of those other disorders that are on there, right? So the little yellow dot is how often it happens compared to general knowledge, right? CMV, we don't have a number up there yet for, they're still looking at that data, but I will give you some preliminary data on what we know. So we know that half of the general population, that's you and I, are positive for CMV by the time we hit 40. Okay. I actually give blood for reasons I don't understand. I am still CMV negative after all these years, and I'm way beyond 40. But so I give blood at the blood bank because there are certain, especially children who are CMV negative, who, let's say, have cancer or something like that going on, and they need CMV negative blood, right? So in general, CMV is totally harmless to the general population. The only time it's harmful is when it is in utero. So it's harmful to the fetus, right? So if the mother is negative, and now we know actually if she gets a mutation, she may get, it may impact the baby, although we're still looking at that. If the mother's negative and she contracts CMV while she's pregnant, it's going to impact the baby, okay? So if she contracts a mutation that creates a very heavy, what they call viral load or heavy presence of the virus in her body, it can affect the baby. But we also know that once you have the antibodies, if you contract a different form of CMV, a different mutation, those antibodies are still going to react pretty quickly, which is why it's more rare for this to happen with a secondary or thereafter infection. We now know from multi-state studies that there are approximately 30,000 babies a year born with congenital CMV, meaning that they contracted CMV in utero, okay? So that translates to about 1 in every 200 babies is born with a CMV exposure, okay? Of that number, many are typical, but also it means that there's about 400 deaths and about 6,000 children with disabilities. The most common disability to happen from congenital CMV is hearing loss. And that can happen either at birth or it can be a delayed onset. So there are children with congenital CMV who have normal hearing until they're 4, 5, 6, 7, and suddenly their hearing changes, right? When you have CMV related hearing loss, it tends to be progressive over time, okay? So I want to be clear. Any person can have and can transmit CMV at any time, right? Any of us. Any person who has a cold may actually have an active CMV virus happen. Kids, babies, toddlers, ages 1 to 3 are the highest risk for both contracting it and spreading it. And by the age of 5, about 1/3 of all children have already contracted CMV. A lot of that wasn't true in my age group when I was growing up, because most of us stayed home in our families before we went to school. But many kids now are in multi-child settings, daycares or whatever. And, you know, we all know what babies do. They put stuff in their mouth and they stick their finger up their nose, and the next kid comes along and he touches the same thing, and then he sticks his fingers in his mouth, and it's easily transmissible, right? So both home daycares and center-based daycares have a very high prevalence of CMV. If you are a parent and you have a young child, you have a 40% increased risk of contracting CMV, because it's very likely that the toddler you have has contracted it. And we'll talk about some preventions, but we all do these things. We share sodas or drinks with our babies. We share ice cream. We kiss them on the lips and it's all slobbery. We're changing their diapers. There's a lot of ways in which we come in contact with bodily fluids that are positive for CMV. So we also know that daycare and early intervention providers are at an increased risk of contracting CMV, and they estimate that risk to be about 17%. Okay. So when we test for CMV, a lot of times it happens because the baby is symptomatic, and we'll talk in a minute about what those symptoms look like. Currently in Delaware, Christiana Hospital is the only hospital that is doing what we call targeted screening. So that means that if a baby fails their second hearing screening, that they take a sample and have it assessed for CMV. Understand, though, that in order for that test to be valid, that testing has to happen within the first 21 days of life for us to know that it's congenital. After about 21 days, we can't say for sure that the baby contracted CMV in utero or they contracted it after birth. So the timing is very important there. And unfortunately, some babies don't get in for their second screen until they're a good month old. That's one of the reasons why in Eddie, we say we follow the 1-3-6. So screening by 1 month, diagnosis by 3 months, and then intervention by 6 months. There is an expanded targeted program, and that is, I can't even see what I wrote there because maybe I'll just get rid of everybody. Okay, and it includes babies who meet any of the high risk factors that we will talk about in a second. And then there is universal screening, in which all babies are tested before discharge from the hospital or within 21 days. That's the other way to do it. Currently, there is only one state that has passed a mandate for universal CMV screening, and that is Michigan. Okay, so when we talk about an expanded targeted screening, those would be babies who meet certain symptoms, either at birth or prenatally. So what would happen, what we would look for is if a mother has a cold or the flu during her pregnancy. I did put a link here where you can look more in a more expanded way at some of the prenatal signs of congenital CMV. But in general, we look at abnormal enlargement of organs, especially abnormal enlargement of the liver and the spleen. We also look for the buildup of calcium salts. So it looks kind of like a plaque in the soft tissue of the brain. We look for abnormalities in the amniotic fluid. We also look at small head circumference. So if the baby's head is not growing and is more than 2 standard deviations below the average, then we consider that a risk factor. And or on the ultrasound, we would see dilation of the lateral ventricles in the brain. Okay. Because CMV can affect babies in many, many ways. Hearing loss is one of the more common ways that it affects babies, but it can affect them in a variety of ways. So here is a list of some of the things we see in babies and or as children get a little bit older. So low blood platelet counts. They call it, the word is petechiae, so it's a rash. They often refer to it as blueberry muffin rash. So it's reddish or purplish spots on the skin, little tiny dots all over the skin. Jaundice is another issue. So that's when the liver is not processing correctly. There are other reasons to have jaundice, but CMV is one of the causes. And the technical medical name is bilirubin. So you have increased bilirubin. Again, small head size, so microcephaly. Being a baby who is small in birth weight is also a risk factor. So a baby who is small for their gestational age, or during pregnancy, they noticed that there was a growth restriction in utero. Okay. A premature birth of unknown etiology is a risk factor. Liver problems, including jaundice. Spleen issues, lung issues, bleeding issues, issues with growth, seizure activity, hearing loss, vision loss, and what the medical community calls mental disability. In education, we tend to call it cognitive disability. So there are a lot of outcomes. We used to think, again, I've been in this field a long time, there was a time when we didn't know that much about CMV, and we thought that the only babies born with CMV had severe disabilities. We now know that's not true, and that many children who are exposed to CMV in utero actually are pretty typical, right? So we talked about testing. There's a couple of ways to test. So one is a saliva test, and it just requires what they call a buccal swab, which is just a swab inside the cheek, like on a Q-tip, right? There's a specific name for it, and it's what Michigan is using, the Alethea CMV assay test. It is the easiest thing to do. It's the most cost effective, and it has a very high rate of accuracy. We do know, however, that if the baby is swabbed right after they've been breastfed, then if the mother has CMV in her blood, it could bring us a false positive. So there is that. They like to, give the baby a little bit of water or wait a little bit. But saliva testing is definitely, among professionals, preferred method. You can also collect urine. Again, that has to be collected and analyzed prior to 21 days. And then there's a way to look at blood. Blood has a higher false negative rate because many states who are using that, including us in Delaware, we use the blood spot. So, you know, every baby gets a heel stick when they're born, and they take blood and it goes on this card and it's tested for, I forget how many, but a number of disorders, metabolic disorders. And then that's sent to Department of Public Health and it's kept there. Every state has a different protocol for that. In Delaware, we only keep them 2 years. In other states, they keep them for much longer periods of time. In some states, they keep them for less time than that. The accuracy of the blood spot testing depends on how the blood spots were stored and how long they were stored, right? So in other words, if I had a blood spot from a baby and it came up positive for congenital CMV, I would say, yes, that baby has congenital CMV. If it comes up negative, the baby might still have congenital CMV. So there's a higher false negative rate in that testing. So what do we do about it if everybody has it? So we know that universal precautions are highly effective. And actually that data all came before COVID when we weren't wearing masks. When I met with the National CMV Foundation a couple weeks ago, a group of us, they reported that CMV, congenital CMV numbers were actually down during COVID because people were taking such precautions with themselves and their children, right? So masking seems to add another layer of protection. Washing your hands is highly effective. It's probably the #1 thing you can do, right? Cleaning areas where children eat or get their diapers changed, making sure that we wipe it down and clean it good after every event. Wiping down play areas and toys that have come in contact with saliva, tears, blood, or urine. And that's, you know, we would like daycares to do that, whether they're in-home daycares or center-based. Not sharing drinks and food with other people, especially kids. Avoiding public drinking fountains. And avoid kissing others on or near the mouth. So what if you're a pregnant woman and you end up with CMV? There is a immune globulin that they give, a serum that they give to pregnant women if they think that this is their primary CMV infection. So the first time that they're contracting it, and it is during their pregnancy. That seems to reduce the impact to the fetus. So that is one thing that can happen. But that also means that you have to know prior to pregnancy whether you are CMV positive or negative. And I can tell you, again, my kids are older, but I fought with my OBGYN over having that test done. They didn't want to do it, and I was demanding it. If a newborn is born symptomatic, then they have 2 medicines, ganciclovir and valganciclovir. But that has to be started by 31 days. Right? So it needs to be started pretty early, and it has some side effects. So it's not just an easy thing to decide. It's a big decision for families and physicians to come to an agreement on what to do. We are hoping for a vaccine within the next 10 to 20 years. The National Institute of Medicine back in 1999 rated CMV vaccines as a priority within the health system, but it hasn't happened. Right now there is there are 10, there's 10 phase 1 trials. So phase 1 trials are the first set of trials they do, then phase 2, and then phase 3. There are 2 that are in a phase 2 trial, and I believe one of them is from Moderna. And then there are none that are in phase 3 trials at this point. But the idea would be that just like the HPV vaccine that we encourage young teens to get, that we would be targeting like 12-year-olds right before childbearing years to have that vaccine. So hang on and we'll see when and if that gets here. So we know that pregnant women need to be highly vigilant with precautions. But again, most pregnant women don't even know of CMV. And that's my point, is that if you don't know, you can't take those precautions. Any of us, when we're pregnant, do all kinds of things. We don't eat this and we don't drink that and we don't smoke and we don't, because we're trying to protect our baby. And I think that if women knew more about CMV, they would be willing to do that as well. But it does, we all should be taking precautions routinely, really. Again, washing your hands is the biggest thing for 15 to 20 seconds. It's just like COVID, especially after you've changed diapers or you've been feeding a young child or you've wiped their nose or their drool, or you're handling, like, cleaning up children's toys. Again, as a pregnant woman or a woman who is attempting to become pregnant, do not share food, drinks, and eating utensils with young children. Do not put your baby's pacifier in your mouth. I know people do it all the time. It drops on the floor, you have nowhere to wash it off. You just stick it in your mouth, lick it off good, and give it back to your kid. I know people do it all the time, but that's not a safe behavior. As well as not sharing a toothbrush with a young child. I never did that, but apparently people do that. They share their toothbrush with young children. Avoiding contact with saliva when kissing a child. So if you're pregnant, you want to kiss them on the top of the head, on the forehead, further back on the cheek, closer to their ear, somewhere where you're not going to get saliva. And then cleaning your toys and your countertops and your other surfaces that have come in contact with children's saliva and urine are good precautions, right? So some states have enacted huge public awareness campaigns. And there are a few states that are taking DNA samples from babies who fail their hearing screenings or who are symptomatic for CMV to further research. Right? Again, it is difficult, very difficult to know if a child has congenital CMV or postnatal CMV if the testing happens after the first 21 days. Currently at Nemours, which is where most of our babies go for confirmation of hearing loss, the ENTs are requesting the blood spot card from the Department of Public Health to test for congenital CMV for all babies who have a confirmed hearing loss. That's what we're doing right now. But again, my point is that there are many children who end up with a whole host of other disabilities that are not tested for CMV. And if we only keep our blood spots for 2 years, and let's say I have a 4-year-old who's losing their hearing, we have no way of knowing if it was CMV, right? So we do also know that children who have congenital CMV, both typical children and children who have a disability from CMV, will release more of that virus in their urine and saliva, etc., from infancy through about preschool age. They call it shedding. So congenital babies do shed a higher amount of virus in their bodily fluids. Okay. But again, many of those children are typical children. They don't have a disability from their CMV. I have this conversation with teachers a lot when I do this presentation for teaching staff of children with disabilities, is that congenital CMV children pose no greater threat to a pregnant woman than the general population. Anyone, anywhere can have CMV at any time, right? So we don't target those congenital kids. I've had lots of unfortunate issues around that. So we know that congenital CMV, or really CMV in general, is considered a protected health information. So like having AIDS, it's protected health information. Sharing that information without consent is technically illegal. But again, doctors put it in reports all the time because they're not looking at it in the same way. It's just medical information and it's very neutral to them. Unfortunately, sometimes when teachers get that information, they misunderstand the virus, they misunderstand the outcomes of it, and they get nervous about having a congenital CMV child in their classroom. And unfortunately, we've had to mitigate some of that and mediate some of that. I always remind teaching staff and administrators that excluding a child with congenital CMV from an activity or a class is a violation of that child's ADA rights. Your ADA rights are your Americans with Disabilities Act rights, anti-discrimination, and that law applies from birth to death. And so exclusion of a child with congenital CMV could lead to litigation. And I always remind staff of that, that's not an okay thing to be doing, right? And I know people do it out of a place of misunderstanding and a place of fear. And sometimes administrators are the ones who are like, oh, well, she's pregnant, maybe this child shouldn't be in that room. I know they're coming from a place of helping, they're coming from a good heart. But again, I think there's a lot of misunderstanding about CMV. So currently in Delaware, we have kind of this grassroots movement that's happening because we would like to see two things. We would like to see screening for congenital CMV. If you're talking to me, I want to see universal screening of all babies. But we would also like to see a public awareness campaign for children of childbearing years so that they know about CMV and they can take the proper precautions. So some of our goals. The first thing we need to do is increase the blood spot storage from 2 years. And I'm advocating for 10 years. So that if we have a baby that isn't tested with saliva at birth, that we have a way of going back and looking for CMV. I would like to meet with legislators and consider mandating universal CMV screenings for all newborns. But I will accept a targeted screening as a compromise. Right now, that's what Christiana's doing, but they are the only hospital that's doing that. And so we are attempting to partner with the National CMV Foundation for some support. They have some project managers there who have helped other states develop legislation. And so we're looking to them for help. One of the things I found interesting was that I would have thought that the March of Dimes would have been all over this and that they would be advocating for this as well, given the number of children who end up with disabilities. And it's preventable. For the most part, it's very preventable. But apparently they have not wanted to partner with the National CMV Foundation. I'm not sure why that is, but I was surprised by that. And then the last piece really is just to give you a bunch of resources of places where you can look at more information, more detailed information, including the 2 consensus summaries that are here. And one is from the US and the other is international, in which doctors have met and kind of said what they think should happen. What I find really interesting is that the American College of Obstetricians and Gynecologists have decided not to tackle the CMV issue because they feel like it's such a common virus that there will be no way to prevent congenital CMV, and it will only cause anxiety among pregnant women and guilt among women who have children with disabilities. So that is currently apparently their take on that, which I find interesting. So I'm going to stop sharing my screen and let's have a conversation.
Thank you, Kathi. If anybody has questions, feel free to put them in both the chat and there's also a Q&A at the bottom.
Yep, either or.
I actually have a question. So you were saying that women aren't screened for this, and you had to ask your OBGYN to get tested for CMV. No, there were 2 medications that you listed that women could take if it was found that this was their primary
infection.
Mm-hmm. So wouldn't that be helpful in, wouldn't that be a reason for pregnant women to be screened for CMV?
From my perspective, yes. Now, again, my children are 27 and 31, so I don't know what's happening now. But yeah, I had to fight for that information. And again, working in educational audiology and working with just hundreds of kids over the last almost 40 years who have hearing loss, I'm sure that I have come in contact with some of them I know. I was often privileged to that information. So I just always was careful, like during my pregnancies, I knew I was negative. So, the audiologist always does this, right? They always put their hand up when they're doing speech screening. I would, when I brought kids down, I put them in the test booth or whatever. When I went around to my side, I just had wipes there and I just wiped my hands down good. And I had a trash can there. I was not making it a big deal. And I was more careful with my second baby than my first one because I did have a toddler at home and I knew I had an increased risk, but it is not, I don't want to say it's hard to catch, but it's not that easy either. You have to come in contact with the bodily fluids. So, I would often have women come into my office and say, I'm working with so-and-so, and I know they're a congenital CMV child, and my daughter-in-law is pregnant. And I'd be like, okay, it doesn't get transmitted that way, right? So I don't want people to be afraid of it. But yes, I think that the more information you have, the more prepared you are.
Right. Exactly. Okay. So from Angie, are those 2 medications only effective if it is the pregnant mom's first CMV infection?
I don't know the answer to that question, Angie. The general thought that, as I understand it anyway, at this point, is that if you've already had a CMV infection and this is a secondary or tertiary or whatever infection, that your antibodies in your own system are going to come to your rescue pretty quickly and minimize the impact. So that's why we think that many babies are born typical, because the antibody of the mother took over, right? The other thing we think that's happening is that, and this makes sense to me, that the earlier in your pregnancy that you contract CMV, the more likely it is for there to be severe disabilities, because the spinal cord, the brain, the entire neurological system is just emerging and developing. So that we think is really different than if you contract CMV when you're 6 or 7 months pregnant and really everything is already formed and the baby is now just growing, right? That's the current theory. Again, I am not a doctor. I'm not an MD. So I don't have an exact answer for you.
And she goes on to say, do you know if this is a medication that is dangerous to the baby? What would happen if it was distributed to women?
I don't know that. I know they use that. I know they use it. It's approved for that use. So it must be relatively safe, but there may be some side effects or some risk factors that I'm unaware of.
Another question. I have hearing loss in my family. I was worried about my 8-year-old because she was a preemie and failed her first test. She was not tested while she was in the hospital. Is there a way for her to be tested now?
So if she's 8 years old and going to school, she should be getting a hearing screening at school from the school nurse. So if she's passing her hearing screening and she's already 8, I probably wouldn't put it high on my priority list. I mean, you certainly can always, and I would encourage any parent who has concerns to schedule a hearing test with an audiologist. But yes, prematurity is another risk factor for hearing loss, just in general, CMV or not. But again, if all of her speech and language milestones are typical and she's passing her school screening and she's doing okay in school, I probably wouldn't have a huge need to do that. But again, if you're just that mom who needs to feel better, which is the mom I am, I would probably take them for a hearing test.
But there's no way to be tested for congenital CMV.
Correct. Not in this state, because now in, can't remember what state, maybe Michigan or Minnesota, it's an M state. They found that they keep their blood spots indefinitely. I mean, you could look at a 20-year-old and still take a look at their, again, there's a high false negative. So if it says no, it's not CMV, it might still have been CMV, right? But yeah, I've had lots of kids over the years with who are congenital CMV babies, and they all, from an audiological perspective, they all look different. Some of them have additional disabilities, some do not. Some of them, their hearing progressed more quickly, and others it progressed more slowly. We don't know any of that exact information yet.
Another question, if we had a kid diagnosed with hearing loss later, like say 4 years old, how would knowing whether they had congenital CMV change the course of treatment at 4?
It probably would not. It just, it would help us think about progression of hearing loss very differently, because most congenital CMV babies have progressive hearing loss, which can then change some of your thinking about what language modalities you're using, whether you're going to look at cochlear implantation, how often you're going for hearing tests, what behaviors you might be looking for to notice that your child's hearing has changed in between appointments. So it might impact some of that. It won't, there's no way for us to stop the hearing loss. Right.
Okay. Anybody else? Any questions or comments? All right, I think that was it. Well, thank you, Kathi. We appreciate this so much. This was a great presentation.
I hope you all will join me in my kind of push to, you know, keeping blood splats longer costs the state some money. I was kind of laughing. I'm like, can we take everybody's $300 back? You know, like, I just, to me, it just seems like we could do a better job at preventing that. And not, again, let me be very clear. I am not that person who thinks that children with hearing loss, that we should eradicate hearing loss. I'm not saying that at all. But many of those children do have significant other disabilities as well. And it just seems like we could prevent all of that trauma for the family if we did things a little differently.
Absolutely, I agree. All right, well, thank you. Thank you, everybody. Thank you to the interpreters. Thank you for joining. Kathi, actually, would you mind putting in your email into the chat just in case anyone has some questions to ask you?
Here we go. Just making sure I typed it right.
Perfect.
I'm a good speller. I'm a terrible typist. So
I'm both. So. All right. Thank you, everyone.
Thank you, everyone. Bye-bye.
Bye.